teacher and assistant choir director who would sit right in the front, Mrs. McGee, and she would be beaming, like no matter what happened, you could just look at Mrs. McGee and everything was right.
Hi everyone. I just want to say before I launch in, I know you're all eating. Please feel free to keep eating chips, sandwiches, whatever. Make some noise. That's okay. So I want to start by saying good morning and welcome to Let's Discuss. I am Courtney Wood. I'm the Chief Financial Officer for Fora Health, and I'm here with our in-room audience, PNC Live Studio, and we also have an online audience that we're glad has joined us. This is our first event in our spring session, and as you probably noticed, we made a few changes to this series. We have a new time this year. We have 3 events this spring, and then we'll take a break during summer, and we'll see you all again for 3 amazing keynotes this fall. We are so excited that so many of you have joined us today to hear Dr. Jennifer Hartley's keynote on Oregon fentanyl crisis, what we have learned and the most current treatment approaches. Before I introduce her, I want to say hi to all the patients and staff at Fora Health. They're all streaming live from our facility, so hi guys. Fora Health's mission is to provide treatment, care, and advocacy for all who are affected by substance use disorder. As a community, I think we're all very aware of the complex challenges we face around addiction and homelessness. Our team at Fora Health works every day to bring hope and healing to our hurting community by providing withdrawal management, residential care, and outpatient services. We are pleased to provide this incredible educational opportunity to this community. As part of our effort to bring healing, we want to create more of a conversation about recovery and treatment and highlight how every individual can heal from substance use disorder. I also want to take some time to recognize our generous sponsors who make this educational series possible. So to the trustees of the Wheeler Foundation, Cambia Health Foundation, Care Oregon, Edlin and Company, and New Narrative, thank you for your incredible partnership. We've worked very hard to make this high quality event accessible and free of charge. We'd like to invite you to join us in this effort. You can join us with a donation. Just click donate when you come to our website to give online. A few reminders before we get started. This is actually different than most of our series. So this presentation is being recorded and it will be available later. If you are here for CEU credits, take a moment to pay attention to this part of the announcement. So for those in the room, make sure you're checked in. You can check in at the registration table and pick up your evaluation form. Make sure you fill out your evaluation form and give it back to the team. If you need an evaluation form, raise your hand. Our team is passing them out if you need them. While they're working on that, friends online, please check in using the link in the orange bar above the presentation screen or the orange button in the right-hand corner. You will also need to complete the evaluation form. The evaluation form is located in the right-hand corner of your screen. Please download the form, fill in your information, and after you complete it, send it to development@forahealth.org by Wednesday, April 2nd. These instructions are on the form, so they don't have to remember that email address. All CEU certificates will be emailed to everyone by Tuesday, April 8th. So for our online audience, you can view the presentation slides by clicking Event Slides in the upper right-hand corner. After the presentation, we'll have a Q&A, and those online can submit questions during the presentation. There is an Ask Question button below the viewing screen. We'll keep track of all the questions and answer as many as we can at the end of the presentation. Okay, one last item. Please, everyone, you can eat and make as much noise eating, but silence your cell phones. Okay, this is the part that I really wanted to do. I am especially thrilled to introduce our speaker today, Dr. Jennifer Hartley. Dr. Hartley is our Chief Medical Officer for Fora Health Treatment and Recovery. Prior to her role at Fora, Dr. Hartley served as Fora's Medical Director and Director of Innovation. During this time, she developed innovative approaches to address the challenges posed by fentanyl, demonstrating her commitment to advancing patient care and treatment methodologies. She has spoken nationally about her newly developed protocols. Sorry. Dr. Hartley also received her undergraduate degree from Princeton University, her medical degree from the University of Vermont, her doctorate in anthropology at Brown University, and her master's in Oriental medicine from the National University for Natural Medicine. She has also completed a fellowship in addiction medicine at OHSU. That's a long list. Dr. Hartley was recently named as one of the top doctors in addiction medicine by Portland Monthly. Beyond her impressive credentials, Dr. Hartley leads the team with her heart. She combines her medical knowledge with kindness and compassion. I want to underscore this part of the introduction. The compassion, I think, really sets Dr. Hartley above and beyond when she is providing care. And this care, this expertise, all of it is helping save lives. So please help me welcome Dr. Jennifer Hartley.
Thanks. I actually don't need that. Thank you, Courtney. And thank you to everyone who is here in person and everybody who's joining us online. I'm so delighted that we have this time together today. I'm just grateful that so many people are interested in this topic, and I recognize many faces in the room, and now I would recognize many more if I could see everybody out there in the ether. So thank you for being here. I'm a family physician. I never thought I would be doing this work. I thought I would spend my career delivering babies in some small town somewhere, like where I grew up in northern Maine. And the work found me, as I think many of the most important things we do in life do. And now I really can't imagine doing anything else. So to frame what I'm going to say here today is, I just want to say this is not meant to be a highly technical talk. I hope that you come away, I hope that everybody comes away from it having learned some really practical things. If there are clinicians here who want to talk later about really getting in the weeds of approaches, I put my email on the final slide. Please reach out to me. I could talk about this topic for days and days and days. But really at the heart of what I'm going to talk about today is a story of the human spirit and of how we learned at DePaul Treatment Centers, then Fora Health, which then became Fora Health, how we learned to adapt to change, and how we learned to adapt to change rapidly and change that we didn't see coming. And I think that that is something that is one of the hardest things for us human beings to do. We don't like change, then when we don't see it coming and when we have to change quickly. And it's a lesson that I have had to learn over and over and over again in my own life. And every time I learn a little bit more. So with no further ado, here we go. Let's talk about the Oregon fentanyl crisis. What we've learned over the past 5-ish years, what we're doing now, and what's on the horizon. So before I really get rolling here, I need to say some thank yous. And I want to be really clear, this is not my work that I'm going to talk about, it's our work. There are a cast of hundreds surrounding me here who have had a part in the work that we have done and are doing at Fora. So if I named everybody's name, I'd be here for the next week naming names. But there are a few acknowledgments I think are really important to make. Number one, I really want to thank from the bottom of my heart Dr. Jessica Gregg, our previous Chief Medical Officer at Fora. She was also my mentor and teacher at OHSU in the Addiction Medicine Fellowship. We came to DePaul Treatment Centers together. We lived through this together, and it was really, without her wisdom, her guidance, her knowledge, and her always willingness to listen. Every time I ran into her office and said, I have an idea, she always took that seriously, listened, and we would not be where we are today without her. So thank you, Jess. Also, I need to give tremendous thanks to the Fora nursing staff, present and past. Again, we all did this together. Their skillful, compassionate work made everything possible and continues to make everything possible. every day and every night. So I am so proud of them, and I am so grateful for the opportunity to work with them. And then thirdly, and most importantly, I need to thank our patients, who number in the hundreds and in the thousands now, who have come to us for help withdrawing from fentanyl, being treated for opioid use disorder. Their deep generosity of spirit in the midst of excruciating suffering, sharing with us their experiences, what was happening for them, also has made all this possible. So I want to thank each and every one of them for helping us do this better. All right, so to get right to the chase here, to cut right to the chase, fentanyl, I don't have to tell anyone here that fentanyl poses unique challenges for the treatment of opioid use disorder. Unique challenges, to say the least. What we found was that collaboration was and will continue to be absolutely critical to addressing the crisis. And we also found that it is incredibly important to pay very close attention with great love to each patient and their individual experience. So we're going to talk about when did fentanyl show up, why it's different than heroin or prescription pain medications, both for patients and their experience and for providers who are trying to take care and treat those patients. We're going to talk about innovative strategies we used and continue to use, and the collaboration, again, that got us to where we are today, and then look at some next steps. So to frame this, and you don't have to get too focused on the details of this graph, but basically what it's showing is the three waves of opioid overdose deaths, starting in the 1990s with prescription opioids, then shifting in around 2010 to a rise in heroin overdose deaths as people transitioned to heroin when they couldn't get prescription opioids. And then wave three, by far the most significant, which involved synthetic opioids, i.e. fentanyl, which started in about 2013, primarily on the East Coast. So we'll come back to this graph later. So in 2019, in the summer of 2019, I started my one-year addiction medicine fellowship at OHSU. The focus of the fellowship was really primarily on addressing the opioid crisis. And our patients were primarily patients using heroin, either IV or IM, so intravenously or intramuscularly. And there was a tremendous focus on education around the use of buprenorphine to address withdrawal and as a maintenance medication to treat cravings for opioids. So a bit about buprenorphine. Buprenorphine, and again, this is the generic, most people on this call know this, but buprenorphine is the generic name for a variety of brand names. The most common ones are Subutex and Suboxone. Buprenorphine in pill form or in film form. It also comes in little films that are kind of like tiny little Band-Aids. Both of those forms of the medication are taken by putting them under the tongue and letting the medication dissolve. So why is buprenorphine so great? Well, it decreases opioid cravings, it treats withdrawal, and it reduces the use of opioids and opiates. Another really terrific thing about buprenorphine, and part of the reason it was such a game changer for people with opioid use disorder, was that unlike methadone, which is the other opioid medication that is approved for use to treat opioid use disorder in this country, buprenorphine can be prescribed in any setting. So you don't have to go to a particular clinic to get it. There are no particular rules around it. Originally, when it was first approved for the treatment of opioid use disorder, providers had to get special waivers called X waivers that involved a day of training. You don't have to do that anymore. Any provider can prescribe it in a family doctor's office, you know, in the middle of the woods in a small town somewhere. And so that was really, really terrific for so many patients because it turned treating opioid use disorder into something that that could be done without all of the lifestyle accommodations that are required to go to a methadone clinic. Again, why is it so great? So we know from really good data that patients taking buprenorphine are significantly more likely to engage in and remain in other kinds of treatment, so behavioral health treatment for substance use disorder compared to people who are rapidly tapered off medication in a rapid withdrawal setting. And then the main reason, right, why it's so great is that people with buprenorphine in their systems live. They get to live their lives. Again, we're not going to spend a lot of time on this graph, but a really interesting thing about buprenorphine is that not only does being on it reduce mortality, so reduce death from overdose, which kind of makes sense, right? But it actually reduces death from all causes. So people just die less if they are on medication. So, how does it work? And this is really important to the rest of what we're going to talk about today. So this is one of my favorite graphics to talk about buprenorphine. So all opioid or opiate medications, and just to that term, opiates are medications derived from natural sources, and opioids are synthetic. So I may use the term interchangeably. So all opiates and opioids work primarily by binding onto a class of receptors in the brain called the mu receptors, MU. There are other receptors involved with opioids, but these are really the main deal. And so what they do, so that green Death Star thing up there, that represents what we call full agonist opioids. And that is essentially all opioids are opiates. So all opioid pain medications are in that class, also heroin, also morphine. So what all of those things do is they bind onto that mu receptor, that purple cup there, and it's kind of like a light switch. It turns the receptor on by binding, and then it sends signals to the rest of the brain and then the rest of the body. And what those signals say are they treat pain. All of the full agonists provide really good pain treatment. They also treat withdrawal. They also, depending on where people are with their use pattern, can either cause euphoria or simply treat withdrawal and treat cravings. So buprenorphine is actually in this country, the only medication that is widely used in a class called partial agonists. And what that means is that buprenorphine binds to these same receptors, so also binds to the mu receptors, but binds it's not a perfect fit. So it's a partial stimulation of the receptor. And what buprenorphine does is also create a signal, but it's a different signal than all of the full agonists. So buprenorphine can also be a very effective pain medication. It's not used as much for pain in this country as it is in Europe, but it is a pain medication. It also is very effective in treating withdrawal and treating cravings. Notably, it does not produce the same feelings of euphoria that all of the full agonists do. Another really, really amazing thing about buprenorphine, the list goes on, is that all of the full agonists share the characteristic that you can just give more and more and more and get more and more and more effect and more tolerance if you're using them chronically. To the point where if you go up high enough and fast enough, you reach the body's what we call the threshold for respiratory depression, which simply means the person stops breathing, and that's an overdose, and they die. Buprenorphine is different in that it has what we call it reaches a ceiling beyond which you can give more and more medication, but it doesn't do anything more. And that ceiling is well below the body's threshold for respiratory depression. So that's another reason why it's so terrific, is that for all intents and purposes, which with just a few caveats, you can't overdose on buprenorphine. So it is a terrific medication, and it was absolutely transformative when it came on the scene here to treat opioid use disorder. One big trick to buprenorphine is part of the reason also that it's really so great. So it has a really tight affinity for that receptor. The medical term is it's a high affinity binder. All that means is that as compared with all of the full agonists, it will bind onto the receptor the most tightly. So the good thing about that is that if somebody has buprenorphine in their brain and they use a full agonist, they will be protected because that other full agonist can't get on there and kick the buprenorphine off. However, the reverse is not true. So if somebody comes in with a brain full of full agonists and they are given, I think I'm getting ahead of myself on the slide here, I'm getting so excited. No, they're given buprenorphine, a big dose of buprenorphine right off the bat. That buprenorphine will come in, it will pull that full agonist, whatever it is, off the receptors, bind instead. And that feeling of going from full agonist stimulation to partial agonist stimulation, if it's done like that, feels terrible. It feels like horrible, horrible withdrawal, like going from 0 to 100 over the course of about 20 minutes. So that is something that obviously we don't want to do. Nobody wants to do. So the way that providers were always trained to start buprenorphine was to, there are kind of two ways to do it that lead to the same place. Basically, you can let the patient know to stop using any opioid for about 12 to 16 hours for short-acting opioids like heroin or oxycodone, 24 hours for longer-acting prescription medications, or about 36 hours for methadone. There's also the other method is to assess with a scale called the COWS, which stands for Clinical Opioid Withdrawal Scale, which measures withdrawal symptoms. And when you get to a certain number, it means you are likely fine to start buprenorphine. So then once you get to that point where there are enough empty receptors, then you would start buprenorphine, and the original starting dose was always 4 milligrams. Nobody really knows why it was 4 milligrams, but it was 4 milligrams, so you gave 4 milligrams. And then you slowly went up over the course of a few days until people reached a maintenance dose, and the right maintenance dose was one where people felt no withdrawal and didn't have cravings to use. And this could be done at home. It was originally done in doctors' offices, but then everybody realized, wait, this is, you know, if you follow the recipe, there is a recipe that you got to follow, but it could be done at home. And it was fairly easy to support those early withdrawal symptoms that people would have with comfort medications to treat nausea, to treat anxiety, to treat some loose stools while people waited to start the buprenorphine. So if you followed the directions, it was easy, and it really felt like kind of a true miracle. And this quote, I've saved it all these years because I just thought it was so, it really summed up what buprenorphine did for people. This was a patient that I took care of at the Blackburn Center. I was a fellow the year Blackburn opened and worked in the M3 program, which was one of the, I think, the first low-barrier walk-in buprenorphine clinic in the city. And this is a direct quote from a patient I took care of. So this is where things were in the fall of 2020 when I finished up fellowship and landed at DePaul Treatment Centers, not too far from here on Southwest Washington Street, as the medical director. What I didn't know, and what nobody knew at that point, was that if you look at these curves, we were right there. So we were just before the storm was going to hit, and things were going to get very dangerous, very difficult, very quickly. I think it's also worth highlighting that another thing had happened early in 2020. COVID had hit, right? And so the public health community, the medical community, the world was really pretty darn focused on COVID and everything that was going on with that. So there was a lot going on. Notably for us, there were big periods of time where there were shortages of medications that we used in our withdrawal management facility. There were periods where pharmacies ran out of buprenorphine. We had shortages of Narcan. There were periods where we were hoarding it downtown, and we were a treatment center. So there were a lot of reasons. Also, many people were struggling, were returning to use in the setting of just all of the isolation and loneliness that COVID involved. So that's where we were. Oh, and I meant to do this at the beginning, but it's a good time to do it now. As Courtney alluded to, and most of you know, at Fora we provide a big continuum of treatment, levels of treatment, everything from inpatient to outpatient and everything in between. Most of the work that is I'm talking about in this presentation was done in our inpatient withdrawal management unit. And so that is a 24-bed, it was 16 beds when we were at DePaul downtown, dorm-style setting that is staffed by nurses 24/7. But we're not a hospital, so we don't have hospital beds. We have beds in a dorm with a lot of compassionate care, nurses taking vitals, but no continuous monitoring. So that's the setting that most of this work was done in. And then we used a lot of what we learned in the inpatient setting to apply to our outpatient program. We admit to withdrawal management 6 days a week, soon to be 7 days a week. We open the door and admit people right off the sidewalk. So we get a very high volume flow of patients, many of whom are coming directly out of houselessness and all kinds of vulnerable situations. And we also tend to get people who have tried other things before. We may not be their first choice. So, or they've tried this at home, or they've tried things on their own and haven't succeeded and come to us for help. So that's the patient population that we're seeing in our inpatient unit. So how did fentanyl show up in Portland? Well, it showed up as blue pills. And I think I don't need to say this to anybody here, but I think it's worth highlighting, like, there was no announcement, right? Like, okay, fentanyl's here, get ready, to figure this out. It showed up very insidiously and kind of trickled in. And so we didn't have any idea at first what we were seeing. Many people initially who were buying these tablets thought that they were buying prescription oxycodone. And then what we would see, one of the first things we saw was that people's use would escalate unbelievably rapidly. So we often have people who return to withdrawal management multiple times, and we'd see people who would come in with, using 3 to 4 pills a day, and then you'd see them a couple months later, and they were using 10 to 15, and a couple months later, and 30 to 40. And we would also see patients who had been using pretty stable amounts of heroin for years, who would start using fentanyl because it became difficult to find heroin, and they too would have these extraordinarily rapid escalations in use that we had just never seen before. So how did it show up clinically? It showed up in a number of ways. And I should say that at this point in time, treating opioid withdrawal in our withdrawal management facility was pretty routine, right? We had that recipe, we followed it, we gave people comfort medications, they did well, they went home feeling pretty good. If we were sending people out to the emergency room or the hospital, it was typically for alcohol withdrawal, for DTs, or some other medical complication. But we didn't send people to the hospital for opioid withdrawal. That just didn't happen. That was fairly straightforward. But what we started seeing is that patients would start buprenorphine according to our recipe that should work, but then they would get sick again a few hours later or even the following day. They would also wait up to 72 hours, so way, way longer than they should have had to wait. And then they would start and feel worse after starting. And we also found that patients would continue to have terrible cravings and withdrawal symptoms even on what was then the maximum recognized buprenorphine dose of 24 milligrams. So, and this all just kind of started happening. And we didn't know what was happening. We knew fentanyl was probably coming because we knew it was on the East Coast first. But again, there were no markers that said, oh, this is what's going on. So it also showed up in a different withdrawal picture. So opioid or opiate withdrawal, the old adage is that alcohol withdrawal doesn't feel so bad, but it can kill you. Opiate withdrawal isn't going to kill you, but it feels like it's killing you, and it kind of makes you wish that you were dead because it's so bad, right? Alcohol withdrawal is pretty bad too. I just want to highlight that. But So for anyone who's never seen it or experienced it, opioid withdrawal it's kind of just like a terrible flu. It is miserable. People really, really suffer. And there's a whole, if you think of all the symptoms that you have when you have the flu, that's basically it. That's opioid withdrawal. With fentanyl withdrawal, we saw that, but we also saw that there were certain features of withdrawal that kind of had the dial turned up to 1,000. And most notably, I would say those three features are a profound restlessness, severe, severe anxiety, and pain really localized to the back. Just awful, 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 awful. One patient said, I'll never forget it, he said, I feel like the dope is coming out of my back. And so when I say restlessness, I think restlessness conjures up sort of like someone tapping their foot, or tossing and turning in bed when they can't fall asleep. And we see that is one end of the continuum, but we also started seeing restlessness that manifested as running, like having to move to the point where people could not stay in bed, started running around the dorms and banging. We had the first instance of somebody just banging his head against the wall because he was in such distress. And this was something shockingly different. And you can imagine in a dorm setting with other patients, they are sleeping. Also, not only how much the patient experiencing it is suffering, but also all of those other patients in the room as well. We had during this period the first instance of somebody coming in for opioid withdrawal who ended up, I had to send him out to the hospital because he was in these spasms that I had never seen before, the EMTs had never seen before. We didn't know what it was, so we ended up going up to OHSU on the Hill, and when I followed up, he was intubated in the ICU, and it was so shocking, and unfortunately that was the harbinger. That was the first one, but there were many, many times after that that happened. So the term precipitated withdrawal stopped meaning what it had meant before, because it had previously, it was really clear what was going on. At this point, the lines were getting really blurry because people would experience this horrifying withdrawal picture before they started Suboxone. They would experience it after. They would experience it days later. It was just like all bets were off. Everything we had learned wasn't applying anymore. The COWS scale, which was very reliable and very easy to use, both for clinicians and for patients to use it on themselves, that too became unreliable as a tool. And so what all this led to was something truly horrible. It led to, so again, many patients were coming in because they had been used to starting buprenorphine on their own in the community, either under the guidance of a physician in the outpatient setting or buying buprenorphine in the community and using it themselves. And so what they were starting to experience is these horrible outcomes that we were seeing. And so they would come in to us terrified, understandably, and not want to start buprenorphine, and not want to start, and not want to start, and we would do everything that we could to keep them as comfortable as we could. But then it would just get to the point where we had exhausted what we had, and they would still be so scared to start, but suffering so much that they would just leave and use to feel better. And that, of course, was very, very dangerous. And I was talking to a lot of people during this period that we were trying to figure out what was going on, and I was talking to providers and nurses and other facilities all over the place. And there were estimates that from other facilities that up to 30% of patients were leaving prior to successful induction. And this slide also, I just always want to highlight, it does not take much fentanyl to die. It takes a tiny, tiny amount. So what was happening? So at the time, we had no idea what was happening. We got to the point where we figured out, okay, this is fentanyl. But in terms of what was causing the clinical symptoms we were seeing, we didn't know. So what we do know is we know a lot about pharmaceutical fentanyl, right? We know that it has a high, high affinity at the mu receptor. It's very close to buprenorphine. We also know that pharmaceutical fentanyl it has a short half-life. When it's used a lot in surgical and post-surgical settings. It starts to work fast, and then it stops working fast. But repeated use of fentanyl has a unique characteristic that other opioids don't have, which is that it is stored in the fat, in the adipose tissue. And so over time, if somebody is using it every day, every week, every month for a long time, it is building up in the fat stores. And so also the kidneys that clear fentanyl, we think there's a process by which the kidneys process fentanyl slower with chronic use. And there is also at the same time increased mu receptor desensitization. So anyway, the bottom line was that fentanyl used on a daily basis behaved much differently than fentanyl as it was used in the hospital setting. And so what we surmised and continue to surmise is happening is that there's something, I've heard people call it a washout period, where fentanyl continues to kind of dribble out of those fat cells and kind of battle it out with buprenorphine for those receptors in the brain. Another thing that we recognized is that we kind of talk about fentanyl as one thing. It's not. It's a lot of different analogs. The last I checked, which was now like 2 years ago because it stopped mattering, the CDC had recorded over 200 different analogs of fentanyl. It also is mixed with all kinds of unknown other substances that we have no way to test for, at least in our setting. So there's no consistency whatsoever in what people were and are using. So how did we move forward? So we made a decision to prioritize buprenorphine induction. And that may seem obvious, like, well, of course, isn't that the point? But as I look back now, I think it was actually one of the most important decisions we made because we could have made the decision to avoid precipitated withdrawal. Now, we obviously wanted that. That was a goal, 110%. But by saying we are going to get people onto buprenorphine, thereby helping them meet the goal that they came to us for, but also keeping them from dying when they leave our care, by making that the primary goal, it shifted us out of this fear-based thinking into goal-based thinking. And again, this wasn't something that I was thinking through that clearly at the time, but when I look back, I really think that it made possible a lot of what came later. So the other thing we did was we remembered that we weren't alone. Everybody was in this together. So Dr. Gregg just convened a working group. We had clinicians from a bunch of different settings, OHSU, Providence, Kaiser, the VA. We met on Teams every other week for an hour, and we just talked. Everybody talked about what they were seeing in their various settings. We talked about articles. We exchanged thoughts. And that was actually incredibly helpful. We also did a mad literature review on approaches used in other states, other medical systems, and also reached outside of the addiction medicine literature and looked at literature from other fields of medicine. So we looked at and discussed low-dose inductions, high-dose inductions, and every possible way that we could address restlessness, anxiety, and pain. So I'm going to go through pretty quickly here, what is a low dose or a micro induction, what is a high dose induction, because these concepts are important. So a low dose buprenorphine start is kind of like a sneak attack. That's why the Grinch is on here. I just love him. It's also, I think of it as like the Trojan horse approach. So we had a lot of experience with this because we actually had done Dr. Gregg and I worked on the very first case at OHSU of low-dose buprenorphine induction, my very first week as a fellow, and then By the end of that year, it was the standard of care. This was how we did all buprenorphine induction in the hospital, and we were able to publish on it. So basically, the concept is, and this is one of the original kind of first low-dose induction protocols. So the concept is basically that you are, if you think back to those receptors, you're continuing to give somebody in the hospital setting who might need to have pain treated, you're continuing to give them full agonist medication, so oxycodone, hydrocodone, to treat their pain, while you're slowly sneaking in that buprenorphine, and you're doing it kind of under the radar of the brain, so that you're doing it in small enough doses, slowly enough that the brain doesn't notice. And so then you hit a tipping point while you're still giving the oxycodone to treat pain, or the Dilaudid, which was often our choice. And then you get to a point where you hit this tipping point and there's more buprenorphine in the brain than there is full agonist. Then you can stop the full agonist and go up on the bup. So again, this had been the standard in hospitals for a couple of years, and the protocols had gotten faster and faster as people realized that, just got better at doing it. So we went back and looked at all of the low-dose protocols that we could find. We also looked at high-dose induction, and this is basically the total opposite approach. And this approach was pioneered in emergency departments. The first big study was in an emergency room in Oakland, California. And essentially the concept here is that you wait the same amount of time that you would wait for a traditional induction. But then instead of giving that 4 milligram or 2 milligram dose and slowly going up, when you're in this window for potentially precipitating withdrawal, instead of doing that, you just like go for the gold. You just load the receptors up with buprenorphine and get people feeling better faster. And this approach obviously makes a lot of sense in an emergency room setting where there's not a lot of time to work with. So we looked at the literature that was available related to this approach. And how did we move forward? So we really just embraced innovation. We said we're going to figure this out based on the data that we have, none of which is exactly applicable to what's in front of us. But it has a lot of, there are pieces of it that we can use. We also became anthropologists of fentanyl, and this was a term that was coined by one of the other clinicians on the working group. Margaret Mead, I have a background in anthropology, and so got her in here. Ironically, she's reading a book. She's not out in the field. But what does it mean to be a, oh, and I have to highlight, because, I mean, this is really speaks to what we were doing. Her famous quote, which I'm sure everyone has heard, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." So following Margaret Mead, we really returned to a prior lesson that we had learned at OHSU as we started microdose approach. And this is literally what we started with at OHSU when we did the first microdose induction. This was somebody's kind of handwritten recipe for doing it that Jess had done a screenshot off of her Twitter feed and saved it. This is what we used to start. So, so we really were grounded in that lesson of use what you have as far as data, and then pay really, really close attention to your patients. And so what that looked like for me and for our nursing staff was really sitting with patients. So I spent many, many hours sitting with patients on their beds, rubbing their backs, talking to them about what they were feeling. This was, again, during COVID with the terrible workforce shortage. So we were so short-staffed with nurses, and in hindsight, it was a gift. It didn't always feel like one then, but I would go in and I would work a lot of nighttime nursing shifts. And so what that did was allow me to see the full 36-hour course of what would happen to somebody in their withdrawal picture as they went through it. This also looked like just very, very constant communication with the nursing staff. I mean, there were nights that we were on the phone every hour, and they'd say, well, I'm seeing this, and I'd say, well, let's try this, and then they'd call me back and say, well, it's a little better, and then we'd try something else. And we just really immersed ourselves in the patient experience. So we also, again, through this process, really optimized the adjunctive medications that we had. We had all these workhorse medications. I'm not going to go through them all. It's not really that important. But we had all these medications that had been our standards for taking care of withdrawal. And we experimented with using higher doses, dosing them more frequently. We also started using medications that we had never used to manage opioid withdrawal, namely gabapentin, which we used a lot for alcohol, and benzodiazepine withdrawal, not for opioid withdrawal. And we started using some of the atypical antipsychotics. We really were just looking for anything that made people feel better. So another really key thing that we did, and this came out of some case reports in the pain literature. So again, like the importance of casting the net wide and thinking outside of the box and looking for solutions outside of the box. This was not in the addiction medicine literature, but there were a number of case reports in the pain literature of rapid low-dose inductions that started with 1 milligram doses of buprenorphine. Now, what was the big deal about that? Well, previously, low-dose inductions had started with 0.5 milligrams. And in the hospital, this was really easy because in the hospital, most hospitals, not all, but many hospitals have access to buprenorphine patches that go on the skin that release buprenorphine to the equivalent of about 0.5 milligrams. In the outpatient setting, so buprenorphine comes in 2 doses, 8 and 2 milligrams. Why that is, I have no idea. You would think for such an important medication it would come in more different doses. It doesn't. So it's pretty easy to cut a 2 milligram tab in half. To cut a 2 milligram tab in quarters is like real hard. It just turns into crumbs. So in the outpatient setting, people could do that and just kind of, you know, ballpark, this is about a quarter. In a medical setting, we really couldn't do that. It is possible to cut buprenorphine films more precisely, but it's kind of a big deal. You have to store them in a particular way. We really didn't have capacity to do that in our setting at the time. So the fact that we could move ahead and have some definitive evidence or some evidence to say that 1 milligram doses would work was a real game changer. So initially, we started these 1 milligram doses with a recognition of the psychological component of what was going on for people. This is Carl Jung here, who is one of the great wisdom teachers of my life. So I put him in here to just represent the fact that we really were looking at the whole person, not just the physical being. Because what we saw was that people who had experienced precipitated withdrawal in the past really would develop completely understandably, this horrible fear that was really to the level of like a PTSD response. And the anticipation of withdrawal, of precipitated withdrawal, or of things feeling so awful was so severe that it almost, before anything was even happening, their minds had kind of launched this just nightmare picture, and they were, you know, so afraid to take buprenorphine. So the hope was that by taking little tiny doses, that fear, and realizing, oh, I'm okay, that fear would be mitigated and they could take larger doses more comfortably. So, so that was the initial thought process behind those 1 milligram doses. We later learned that there is some evidence that even tiny, tiny doses of buprenorphine can help start to resensitize the receptors. Okay, so all of this led to the development of what we called our micro-macro protocol, which the nurses basically immediately dubbed the M&M protocol. And so in a nutshell, what it did was start with low-dose buprenorphine, both for the physiological and the psychological benefits. It also was really an attempt to kind of build a roadmap around the experience because both for patients but also the nursing staff, this whole journey to starting buprenorphine, making that transition from fentanyl, had become this just very chaotic kind of this path that we didn't know where it was going or how long it was going to take to get there. So what we wanted to do was say, here's the roadmap, here's where we're going to get, and here's how we're going to do it. And so we really made an attempt to find the sweet spot where we could then give people larger doses of buprenorphine and have them do okay. And then we also, kind of the wraparound philosophy of this protocol was then to give people a lot of sedating medicines to keep them asleep as much as possible and treat that terrible discomfort and fear. So that was kind of the general concept. Here's the protocol. You don't have to look at it, but it very much marched things out for the nurses. It was very clear they could give medications and then focus on other nursing comfort care. And it was about a 3 month. It was about a 9-month process that we went through initially of gathering information, patient experiences, reviewing the literature, writing the initial protocol, starting to use it, adjusting it based on patient feedback and experiences. And then once we had been using it for 3 months, we did a chart review and it turned out just about half and half. So 42 patients on our standard induction protocol and 40 patients on the M&M protocol. And we definitely found that the M&M protocol led to significantly better outcomes. And we published a letter in the Journal of Addiction Medicine, and we actually presented at the ASAM conference on this approach to a big audience, because everybody was struggling in the same way that we were all over the country at that point. And for a while, things were going pretty well. During this period, the nursing staff really worked hard at optimizing non-pharmaceutical interventions and supports. We pulled a lot from labor and delivery, because there's a lot about fentanyl withdrawal that's like labor. So we did a lot of, this is on the right is Nympha, our assistant nurse manager. She was a floor nurse working knock shift during this entire era, did a lot of amazing work. That's Eliza, our long-term tech, who also lived through the whole thing. So what did we do? We got people into the shower with essential oils. We used a ton of hot water bottles for that back pain. We did a lot of back and leg rubs, particularly with Icy Hot. We used fans. We had acupuncture teams from NUNM come in and do acupuncture. We encouraged, to the extent that we could in our dorm setting, gentle movement, like back stretches with yoga mats. So we were trucking along, surviving, getting people through. I should say we also made sure to discharge people with a bottle of buprenorphine in hand. Not a prescription that they had to go fill, but a bottle that was enough for a week, and an immediate call within 48 hours from our MAT coordinators to see how they were doing. Because we also recognized with fentanyl that there was a post-acute withdrawal that went on that we hadn't seen with heroin. So we really made a huge effort to have immediate wraparound care after they discharged. The other thing, I wanted to do a shout out to Care Oregon too, because it was during this period, I don't remember exactly when, but we really had experienced that 24 milligram, I'm thinking about the time here, where I am here on time and said 24 hour. The 24 milligram max dose of buprenorphine wasn't enough in the setting of fentanyl. We needed to give people more. And so Care Oregon listened to us and other community partners and started paying for 32 milligram prescriptions, which was unbelievably helpful and necessary. So that all was happening, and then the fentanyl supply changed. And people stopped coming in talking about blues and came in using fentanyl powder. Not only smoking fentanyl powder, but injecting fentanyl powder. The majority of people were smoking it, but we did see people injecting. We had stopped seeing any injection for the whole period of blues because people were smoking the blues, but now people started injecting again, and that was even more awful. We thought things couldn't get more awful. They did. People also couldn't tell how much they were using. It wasn't sold in gram weights like heroin had been. So it was, the picture got even worse and even more confusing. So how did we move forward? Well, we, at ASAM, when we had done our presentation, I had the opportunity to talk with some clinicians from California who, there's a program called the California Bridge Program, and it actually had its seeds in that original work on macrodose induction in Oakland, and now it is a program that exists in multiple emergency rooms in California, and they have published a lot of work and have really helpful guidance online, and they did a presentation. And so I was talking with them afterwards, and they had started using Ativan, lorazepam, in their emergency room high-dose induction, so giving 16 milligrams of buprenorphine with 2 milligrams of Ativan. And that initially felt like, oh my God. And I remember talking to just because classically you didn't give benzos with buprenorphine because of a risk of oversedation. But with fentanyl powder, we were again just finding that we just didn't have the tools to keep people sedated enough. And so, you know, what we were seeing was restlessness, again, that was so severe that we couldn't control it with sedating medications. And so we would have people up, and again, in our dorm setting and in our, you know, just beds with no bed rails even, we couldn't keep people in bed, but that they were so sleepy that they were at risk of falling. And that's why we would have to send people to the emergency room. So it was so unbelievably frustrating to be stuck in this place where we just really had no other tools. So increasing lorazepam and adopting this, we added it to the M&M protocol so that all our inductions came with lorazepam, and that helped. It helped a lot. We also added a medication called droperidol. Droperidol is an alpha-1A adrenergic receptor antagonist and a D2 dopamine receptor antagonist. You don't have to know anything about any of that. It's similar to Haldol. It's a very old drug. It was used a lot in the 70s and 80s to treat nausea after surgery, and it kind of had fallen out of favor. But there was a physician at the OHSU Adventist ED. We are right across the street from Adventist, so the majority of our patients would go there. And I started noticing that when they came back, the patients that were given droperidol came back much sooner and in a lot better shape. So I started talking to this doc at 2 in the morning when we were communicating about a patient, and he had trained in Philadelphia and had learned about this approach from an addiction medicine listserv in Philadelphia and started using it. So Dr. Gregg and I met with him and the medical director at Adventist, and we created a pretty cool collaborative protocol so that we had an algorithm that we followed. And then if we got to the point where it became unsafe, we would send the patient to Adventist, and they would know exactly what had happened on our end and could pick it up on their end. So that was helpful as well, but things were still pretty darn bad, and patients were still suffering a lot. So we had really reached the limit of this management approach. This is a picture of my little puppy sitting, you can't really tell, but she's sitting on the edge of a cliff. Looking out. And that's kind of where we were. We were on the edge of the cliff. We were hanging on. But we really had our eyes on, oh, sorry, I'm hitting the mic here, sorry. We had our eyes on another option. And what that option was we knew there was a better way to do this, right? Because we had done it in the hospital. And we knew that better way was to be able to use full agonist medication to treat withdrawal, to keep people comfortable, while we did that microdose buprenorphine approach, right? So what we had right now was simply sedating medications to keep people as comfortable as we could while we got them through. What we wanted to be able to do was to actually treat their withdrawal, to treat the root cause of what was making them suffer. But we couldn't do it because of federal regulations. Hospitals and opioid treatment centers, or methadone clinics, are the only ones that can use methadone to treat opioid use disorder or withdrawal. However, we did know that there was an exemption to these federal regulations called the 72-hour rule. And we knew that people in other states, namely on the East Coast, were using the 72-hour rule in really innovative and interesting ways. This is a study, one of the first studies that came out of some really pivotal work done in Boston using the 72-hour rule to use methadone outside of a hospital setting. So exactly what the 72-hour rule says is that any setting that is not a hospital or an OTP can dispense, not prescribe, dispense 3 days of an opioid medication. It's not just methadone. It can be any full agonist opioid medication to treat opioid withdrawal. So to really drill down on this, because it's important, and big shout out to Dr. Mike Weiner, my good friend and colleague, the former medical director of Hooper, for the content on this slide. So what it does is it allows a setting like Fora or like Hooper to administer, or a family doctor's office in the middle of nowhere, to administer narcotic drugs to a person for the purpose of relieving withdrawal symptoms. This is 3 days only, okay? And then everything turns into a pumpkin. You have to stop. And it's while arranging for ongoing treatment. The medications have to be administered, not prescribed, so you can't send somebody to the Rite Aid with a prescription for oxycodone or methadone. Originally, it said that you could only do 1 day's medication at a time. That was revised in 2022 to allow for the 3 days to be dispensed at once. And then that 72-hour period can't be extended. Once it's up, it's up. So again, what this would allow us to do, 3 days of methadone or another full agonist is just enough to do a rapid low-dose buprenorphine induction. So again, it's just the most extraordinary dance that is happening on the receptor level. It's like this incredible orchestra. So you've got all these gajillion mu receptors in your brain, and so you're able to give, as the fentanyl is coming off those receptors, you're able to give low-dose methadone, and we're using relatively low doses for people, to keep some of those receptors comfortable and happy, not suffering, while at the same time sneaking that buprenorphine on as the fentanyl continues to come off. So what were the challenges? And there were some real big challenges. So you've got to get your facility ready to store a Schedule II medication. For us, what that meant was we got a Pyxis, a hospital-style machine for dispensing medication. That's not necessary. I just want to highlight that is not necessary. It made sense for our setting because we have a lot of other medications and other controlled medications that we're using. You also have to have records, inventory, destruction plan for the medication that you're not using. Again, in our setting, that was not the heavy lift. Staff education is incredibly important. Bringing any full agonist opioid into a treatment setting, it's really important that everybody from the nursing staff to the behavioral health staff understand why we're doing this and what it will accomplish. One of the biggest hoops was actually purchasing the medication. The wholesalers that we buy from didn't understand the 72-hour exemption. They had never heard of it. So that was actually one of the biggest projects. Then it's also a kind of involved process to set up what's called the CSOS, which is an electronic certificate that is required to order Schedule II medications. Again, it is perfectly doable. You just have to follow all these steps on the DEA websites and get things notarized, but you got to do it. So how did we move forward? So we collaborated really closely with Hooper, and really big thanks to Dr. Amanda Risser, the senior SED director at CCC, and also, again, Mike Weiner, who was director at Hooper. I don't think we could have done this without them. We really did all of this hand in hand. We met with programs and clinicians on the East Coast who were implementing the 72-hour rule. We met with the wholesalers, and this was after literally like 1 billion phone calls saying, you legally have to sell us this medication. And they just kept saying, no, 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 no. And so finally, the Hooper crew, we met with them. There were legal people there, and we finally convinced them. We had to show them the statutes and say, we need this, and here's why we need it. So we finally got over that hoop. I will never forget the day that we first got methadone in the building, and I opened that FedEx package, and I started crying because I knew what it was going to represent for our patients. And actually, we weren't ready. We had methadone in the building for a long time before we were actually able to start. But that was one of the great days when that came. We also did a lot of nursing education and education for all of the different departments at Fora Health about what was coming. And all that culminated in our methadone bridge protocol. We call it that because the methadone is truly, it's kind of like the bridge of comfort from fentanyl to buprenorphine. And it is also a very clear, scheduled protocol, so it is clear for the nurses. It's one of the things that we also really learned that I didn't mention that has become a key cornerstone of our program is that we learned the value of scheduling medications instead of having them as needed, because we learned that it is way easier and better for the patient to get ahead of withdrawal, right, than catching up when it's already happening. So this protocol also builds in other comfort medications that people just get before they're feeling uncomfortable. So again, it took us over a year, well over a year, to roll this out. Again, we rolled it out in collaboration with Hooper. They rolled out their protocol a few months before we did. And the day that we started, and it was extraordinary that one of the patients who we had to send out to the hospital on every protocol that we had, every single time he came in, showed up this very first day that we were able to use methadone and successfully got onto buprenorphine for the first time. And I will just never forget walking into the nurses' station, and one of our long-term nurses looked at me with this big smile on her face and also this look of kind of disbelief and wonder, and she said, "They're sleeping." And so that has become, originally we thought we were going to roll it out slowly and only for people who had struggled, and within a couple of weeks of starting this, it just became so clear that this was the way to go. This was keeping people much more comfortable. We were not seeing, we screen people for any contraindications to methadone. We were not seeing any oversedation. We still see, I tell patients when they come in, you may feel no withdrawal in this approach. You may feel some, but we have a lot of other comfort medications we can give you. We still give Ativan if we need to. I don't know that we've sent a single person to the hospital for opioid withdrawal, maybe one on this protocol since we started it just about a year ago. We started at the beginning of April. I should say that we are not combining methadone with protocols to treat alcohol withdrawal or benzodiazepine withdrawal right now. I think there are safe ways to do that. It's done in the hospital. Right now, we've kind of set that limit for our program. But I think one day we will be able to get there. So I'm coming to the end here. I realize I'm like 5 minutes over time, but I'm almost done. I just want to highlight another simultaneous game changer that happened kind of right at the time, or we got rolling with it right at the time that the methadone bridge protocol started. Our outpatient team had started doing a lot of Sublocade, injectable, long-acting injectable buprenorphine. We couldn't do that initially in withdrawal management because the initial guidance, this has changed, but the initial guidance was that patients had to be on buprenorphine for 7 days before the first injection. So that wasn't going to work in withdrawal management with our length of stay. But that all changed with Brixadi, which is the other brand of long-acting injectable buprenorphine, which is a very easy injection to give and to receive. And the nurses could give it to patients who wanted it before they discharged from withdrawal management. So that also was just an incredible game changer, particularly, as you can imagine, for folks who don't have a house to live in and a medicine cabinet, to be able to go out and not have to keep track of a medication, game changing. So in sum, what have we learned? We've learned a lot. We have really, really learned that there isn't a one-size-fits-all approach to starting buprenorphine. We've learned that both low-dose approaches and high-dose approaches can have their place. We've really learned that optimizing comfort medications is important and can make the difference. And we have absolutely confirmed that access to methadone increases comfort and success. We've also learned in the non-pharmaceutical realm that it is so important to take the time to know your patient, know what their goals are, talk through the options to reach those goals, have a game plan, a really clear game plan. Here's how we're going to do it. But also have a plan B and let them know that it's okay to go to plan B. Also really, really optimize use of non-pharmaceutical supports. And I think in the outpatient setting, this can be done even more than we could do in the dorm setting. It's incredibly valuable to optimize this approach. And then we've also learned that kindness really, really, really matters. So the work ahead, where are we now? And there's a lot of work ahead still yet to be done. And I am under no illusions. I think this field is going to keep changing. The drug supply is going to keep changing. We are going to be continually required to change and adapt. right now, I think some of the big work right ahead is to adapt the 72-hour rule for outpatient use. It's terrific that we can use it, Hooper can use it, but there are so many people that don't have access to an inpatient withdrawal management unit. And the 72-hour rule can absolutely be used in other outpatient settings, but the protocols, we have to work on developing that and getting that information out there to the clinicians who need it. There's also really interesting work being done in the emergency rooms, also right here in Portland with long-acting injectable buprenorphine for induction, so just skipping that whole phase of medication under the tongue. That is really interesting, exciting, I think has a lot of potential. And also I just want to highlight that for some patients, particularly patients who have long and very high fentanyl use patterns, buprenorphine is not going to be the right medication. It's not going to be strong enough. And there is a need for those patients to have access to methadone. So there's a lot of work to be done to expand access to maintenance methadone for those who need it. And then I want to move up to like the 30,000 foot view here and also just highlight that in our community, it is so important to work to increase access to housing for everybody. It is real hard. We can do the best work we possibly can with starting medication for people, but if someone doesn't have a safe place to live and supports in their lives, it's going to be really hard to stay on that medication. We also need increased access to mental health care and primary care. Again, many of our folks have substance use disorders and also mental health diagnoses, and if they just get one treated and not the other, often things don't go very well. And then we really, I so firmly believe, need to work on increasing connection to one another and community in our daily life. So how will we keep moving forward, all of us? I should say this drawing, I love it so much. It was done by one of our patients, and I think it just sums up so beautifully this kind of combination of like suffering and love. So we will need courage. We'll need to stay humble. We'll need to stay curious, keep busting the lens higher and wider to look at other options. And we will need to move ahead always with love. At Fora, we have kindness as really our grounding mantra, and I don't need to say anything about this quote. It's one of my favorites. And that's it. So sorry I ran a little bit over there, but that's it. Thanks for being here.
All right, we're gonna open it up for questions. While you guys are thinking of your brilliant questions, I want to share a little story about Jenny. She doesn't know I'm going to share. That I think highlights the compassion factor in the treatment. There was a patient that came into withdrawal management a while back. The admission was incredibly challenging for the staff, and I felt that kind of stress and anxiety in the staff. This patient ultimately ended up deciding this was not the right time and leaving AMA. It was a few hours of trying to go through the admission. And I felt kind of that, like, okay, we're moving on. However, Dr. Jenny went up to the patient, took their backpack, carried it for them on the way out, and just simply asked, is there anything that we could have done to make this experience easier for you? And it was that moment that I was like, that's a huge difference to that patient, to really feel like even during their worst struggles, that someone really cares about their treatment. So, kind of sets us apart, I believe. Are there any questions we have out in the audience? They have some people going around with microphones, so I'm gonna, yeah. If I have to do it, all of you have to do it too.
It's just so they can hear it online.
Why does the federal government make it hard to have methadone in these spaces? What is the thinking behind that?
I don't know that I can answer that question. What I can say is that the way methadone is regulated in this country is not coming from medicine. There's nothing medical supporting the way it's regulated. So I think there are, I don't know. I wasn't even around when these regulations were first made, and I don't know what, I could come up with all kinds of suppositions about the motives behind the regulations, but I don't know. I don't know. But what I can say is that they are, there isn't a medical reason why it has to be done this way. Interestingly, I think methadone can be prescribed for pain in any setting by any licensed medical provider. So the use of methadone for pain is not regulated in the same way that the use of methadone to treat opioid use disorder is regulated. So it's a great question, and I wish there were other people in the room that could give us answers. I'd be curious.
I'm actually pretty loud. Oh, okay, so this works. Dr. Hartley, you're awesome. I really respect the work you do and your knowledge, and it's obvious that you're very compassionate about this population. So, not to cause a disturbance, but I had gone to a conference last week in Seattle, and I love your 72-hour protocol. Mm-hmm. They talked about using ketamine. Mm. And I'm wondering about your opinion on that, or any thoughts.
No, that is a super good question. And so we considered using ketamine, and there are places that are doing it. I spoke with a couple of physicians in other settings that were using, actually in Eastern Washington, using ketamine to treat withdrawal. The reason why, and I was actually pretty into that concept for a while, and I was talking to Dr. Gregg about it, and she was really would always say to me, we need to focus on methadone, and I think she was right, because I think ketamine can be really helpful. And so for a setting, for example, that for whatever reason there are barriers to using methadone or other full agonist opioids, absolutely, I think ketamine can be helpful. But the great thing about using methadone is, again, that it is treating the root of the withdrawal. So it is going right to those receptors and binding on. Ketamine is also kind of sedating people, keeping them more comfortable, but it's not actually treating those mu receptors. So I think that it's a great approach, and I think it should be explored, and I hope that there's more publishing on it. It just for us in our setting, because we felt like we could get to the 72-hour, using the 72-hour rule to use methadone, that just seemed like the better route to go. Yeah. Does that answer your question?
Well, it does, and I appreciate that. And there's probably less stigma attached to using the methadone versus the ketamine. When I first heard ketamine, I was like, really? Ketamine? Mm-hmm. So I appreciate that. Thank you.
Yeah. Yeah, thanks for asking.
So when it comes to using buprenorphine to help people with their withdrawal, and they are ongoingly taking it, how, in your opinion, how long do you think somebody should be taking that for the withdrawal? I think the question is, how long should somebody stay on buprenorphine? Yeah, and then are there withdrawals from buprenorphine, and do you have to titrate off of it? What does that look like?
Super good question. So the question is, how long, once you've been started on buprenorphine to treat withdrawal and then are taking it as an ongoing maintenance medication, how long should a person stay on it? And the next question, is there withdrawal from buprenorphine, and how does one come off of buprenorphine when you make the decision to do that? These are really, really good questions. So there's very, very good data, again, pre-fentanyl, when we're talking about the era of heroin and prescription pain medications, that staying on rapid tapers of buprenorphine, so over a few days or a few months, do not support sustained abstinence. If somebody's goal is to remain abstinent from opioids, it is important to stay on that medication for at least a year. For some people, they're on medication, they're living their lives, they're not having cravings, they're good. There's no reason for them ever to stop that medication. when we put somebody on a blood pressure medication or a cholesterol medication, they're doing well. We don't say, take it for this amount of time, but then let's get you off of it. There's nothing different about buprenorphine. Some people, and this is what I tell patients when they come in, because many people do come in with the goal of, I want to be on it, but then I want to get off it as soon as possible. And I get that. I mean, I just want to honor, I don't think most people want to be on medications, right? But the data really shows that staying on medication keeps people safer, keeps them engaged in treatment, and that was what that early graph showed, and supports their goals if the goal is not to return to use. And I think when the data catches up to fentanyl, that period of time of needing to be on maintenance medication to support success is probably going to be longer. So short answer, no reason to come off it if the person doesn't want to. I always say to patients, stay on this medication. If you get to a point where you decide, I want to taper off this medication, and yes, it does have to be tapered down because it is an opioid, and so if somebody just stops taking buprenorphine, they will experience withdrawal. So it has to be tapered down. So I tell people, so if you get to that point where you think, I want to start to taper my medication, picture in your head, like, if the worst possible thing I can imagine happened to me tomorrow, would I have the resources in myself and in my community around me to not even be tempted to use to deal with that thing? And if the answer is even a teeny weeny little bit like, oh, I think I might go down that road, then stay on the medication. The stakes are just too high. And if the answer is 200% yes, I'm good, then talk to your prescriber and start about tapering. And that taper might take a year, because often the taper starts, emotional issues come up, the taper pauses, then it continues. One really terrific thing about long-acting injectable buprenorphine is that the taper is very easy. Brixadi actually comes in different doses, so you can actually taper down the dose. Even if somebody gets one injection or a number of injections and then decides just not to come back, there is a very long tail, as we say in medicine, and the medication just tapers down over a very long time, months. So I think the advent of long-acting injectables is going to make tapering a lot easier for people who want to taper. So again, the data shows staying on medication supports success. Everybody needs to make their own decision, and it is possible to taper off, but you do have to taper. Yeah.
On a kind of similar kind of vein, what do you think about approaches to opioid use disorder that don't involve medications?
Again, I think that there is no one-size-fits-all approach. I think that the data clearly shows that what works best for people is a combination of medication and other types of substance use treatment, like the treatment that we do at Fora, or that I think many people from other organizations here do in other places. So that is what the data shows is most efficacious in maintaining long-term abstinence. I think, of course, there's tremendous value to so many other approaches. There's value in exercise, right? I know we have folks from Go the Distance here. There is value in so many kinds of behavioral health treatment approaches. There's value in dietary change. There's value in there are many approaches to treating opioid use disorder and every other kind of substance use disorder that don't involve medication. And from a medical lens, medication and SUD treatment, the data shows are the most effective, is the most effective combo. Yeah, does that answer the question?
Do we have any other questions in-house? One right here.
Hey, doctor, thank you for this presentation and your work. One of the most pressing, challenging things we face on the street are individuals who have very severe chronic medical issues and using fentanyl. It seems to disqualify them from detox, but then they get cycled in and out of the ER. And I'm just wondering if there's any ideas for disrupting that cycle.
That's a great question. I don't know what kind of exactly what chronic medical issues you're referring to. Our exclusionary criteria at Fora is simply we can't take people on oxygen, and people have to be able to do their own activities of daily living. I mean, they have to be able to get themselves to the bathroom. That's the one, yeah. That's a really hard one because I don't know of a community-based withdrawal management facility that has that one-on-one nursing support to provide that care to patients who can't do their own ADLs. So I think it's just really a hard one. I think that there is I'm really curious about street buprenorphine. I think there are ways to start buprenorphine in the community. I think again, this is where we need to do some real work in optimizing the 72-hour rule for the outpatient setting, so that we can use that to reach folks who can't come in, to get them through withdrawal and get them onto maintenance medication. And for this population that you're talking about, the most vulnerable, we will not have succeeded until we have succeeded in caring for the most vulnerable among us. So I'm glad you brought this up. And I think, again, long-acting injectables can be incredibly supportive to this group, but we have to find a way to bring the medicine to them, or to be able to bring them to us to administer what they need on an outpatient basis. We are actually starting it and Hooper is already doing a version of this. We are starting an outpatient withdrawal management program, and we're set up to start for alcohol withdrawal, and the next phase is going to be adapting to treat people not in our building with the 72-hour rule on an outpatient basis. So, yeah, really good question, really difficult challenge, but doable. I mean, I really think it's doable.
Okay, I think we have just a couple of minutes left, so I'm going to do a little wrap-up, a little housekeeping here. Let's see. Everyone in-house, please make sure that you fill out those evaluation forms, turn them in. Again, those credits should show up by, I believe it was April 2nd. Yes. Before we leave today, too, make sure you're signed up for the next speaker series if you'd like. May 22nd, we have Mary Ellen Dance speaking about 7 facts about anxiety that will change the way you think. You can also look at all the other series that we have on our website, forahealth.org. And everyone online, same reminder, please send in those evaluation forms. And I just want to say thank you, everyone, for joining us.